And good evening, everyone. Thanks very much for asking me to come talk to you on a subject which is very close to my heart, given I've spent most of the last 10 years researching it. So I'm a consultant trauma surgeon by background and training, and I'm a senior lecturer in trauma sciences at Queen Mary University of London at the Centre for Trauma Science. So I'm going to spend the next 45 minutes talking to you about really everything we know about tranexamic acid in trauma. And really what I want to get across to you is, the wealth of clinical evidence we have now in the various clinical trials that have been published. And incidentally, most of them have actually come from pre-hospital care. I'm going to start with a little bit of background about fibrinolysis so we can get a good handle on what the actual problem is and where tranexamic acid actually has a role to play, both in hemorrhage and also traumatic brain injury. And we can't not talk about it without covering some of the potential risks, albeit small risks. And as you'll see as we go through and dissect the clinical trials, that actually it is quite difficult to tease out what the risks are in a group of patients who are, seriously injured and at risk of dying. And then going to finish talking a bit about some very recent work that we've done and others have about the equity of access to tranexamic acid, which is a sort of fits with some of the other things in emergency care that might not quite be as good as they could be. So first of all, if we go back to the basic pathophysiology of what's going wrong in somebody when they have serious injury and they have bleeding, is that trauma and shock combine to form an acute traumatic coagulopathy. And individually, these two pathological mechanisms will have serious changes in the fibrinolytic process. So fibrinolysis, the breakdown of blood clots, which is not so great if you're bleeding to death, because what you want, obviously, is clots to be made. And there are reasons for this, because you don't want to make too much clot. You really want to localize the clot at the site of injury. But when you have a systemic serious insult to the organism, the human body, then you have problems in actually trying to have just the right amount of fibrinolysis. So in effect, we've gone totally haywire, and therefore we have to have some mechanism by pulling it back, because we're actually breaking down too much clot that's forming. So really, this is my simplistic diagram of what the clotting cascade looks like. It is obviously far more complicated than this. But the basic principles are that you have a load of clotting factors in the bloodstream which assemble on the surface of the platelet, ultimately to make thrombin, which role is to cleave fibrinogen. Fibrinogen is the substrate for all blood clots. This then gets turned into fibrin, and then you have your strong blood clot. There's some other stuff that goes on, which we believe through the work we've done and others, that actually the endothelium produces a protein called activated protein C, and this does some nasty things to those clotting factors, but also releases the brake on fibrinolysis. And so fibrinolysis are these things over here at the bottom of the screen. So plasminogen is activated by TPA, that's released from the endothelium as well. And this then makes a plasmin. And where does tranexamic come in? Well, it actually bumps plasminogen into an inactive form, and so you can no longer form plasmin, and so you've effectively stopped the ability to actually start breaking down blood clots. So simplistically, this is what it does. Tranexamic acid, it acts like a fibrin molecule, because it's got the same sort of ends on the molecule, and that then links into plasminogen, and then it stops plasminogen binding to fibrin. So the clot is therefore stabilized because it's no longer exposed to the fibrinolytic component, which is plasminogen. There's a good little link here. There's a nice video. There's lots of actually good infographics and videos that have come mostly from the London School of Hygiene and Tropical Medicine, because they've been the leading lights in the crash trials, and they've produced some very nice, easily digestible videos, and there's the link there for you. So that's the basic sort of pathophysiology of what's going on. So how do we actually diagnose it? Well, it's actually quite difficult, because there are blood tests that tell you that fibrinolysis is happening, but these are blood tests which are effectively for research or for slow time analysis, because they take about 6 hours or more to give you a result, which is a problem. Now, you will all say, hold on a minute, what about these viscoelastic tests? So anyone that's spent some time in a major trauma center or in cardiac theaters or in transplantation world, these are viscoelastic tests. So these tell you about the strength of a clot and how sticky it is. And TEG and ROTEM are the sort of the leaders in this field. They are good. They are point of care devices. They tell you about fibrinolysis and you can get a result within 15 minutes or so. But ultimately, they're actually quite insensitive. And so this is a problem. If you see fibrinolysis, this is what it would look like on your trace. These are two forms of fibrinolysis. So the blood clot is forming, the amplitude's getting bigger, a nice strong clot. Then you'll see on the left-hand side here, around sort of 30 minutes, it starts to break down. And then by 40 minutes, your clot's basically gone. The one on the right-hand side is what we call fulminant hyperfibrinolysis. This basically is very, very severe phenotype, and most of the patients that have this will die. Now, you rarely see these, though. In all of the patients that you would sample that come in, with traumatic brain injury or hemorrhage, you would see this in about 5 or 10% of patients. That's regardless of whether or not the patient's got tranexamic acid, because these tests are actually insensitive, so you do not see very much of it. But then you might say, well, hold on a minute, we're giving tranexamic acid to all the patients because that's what Crash showed us. So surely aren't all those patients hyperfibrinolytic? Well, the answer is yes, they are. The test is just not good at picking up hyperfibrinolysis. So you've got to have extreme levels of fibrinolysis to actually register on these tests to say that they're fibrinolytic. And this is what we did in a study here a few years ago now. So PAP is that enzyme test, that ELISA test that takes about 6 hours to do. And if you link, so we took samples from 300 patients and we said, right, we'll measure your long slow test, your PAP level, and then we'll also measure you on the ROTEM test. And then we'll look at those patients who on the ELISA test are fibrinolytic. So they've got a PAP level of more than 1500. And then we'll look at those patients also who have got the threshold for maximum lysis on the ROTEM test of greater than 15%. And you'll see the group that has both of those things that are registered, that's the severe group. If you don't have either of those, then you're the normal, so you have no fibrinolysis. But obviously there's this group in the middle that have the enzyme test that says you've definitely got fibrinolysis, but you're not registering on the ROTEM test. And lo and behold, what you'll see is that most patients actually fall into that middle group. So we know if we took the really accurate gold standard test from the lab, they would have fibrinolysis. But when we measure them on these ROTEM tests, actually, they're not triggering. And this is about 60%, so 2/3 of your patients. If you then take it into the severely injured cohort and look at those patients who have that middle group again, actually, it's most of your patients. So this is a long way of saying this is your evidence for why tranexamic acid is indicated in literally anyone with severe injury, because we know that there is huge activation of the fibrinolytic system and it's rarely seen on these tests. So you shouldn't be waiting for a ROTEM test or any other form of point of care diagnosis, because we know that literally most of your patients have hyperfibrinolysis. Okay. Now, the other side to that is something a bit weird. This is called hyperfibrinolysis. So this is somebody that seems like they have low levels of fibrinolysis. So this is like the opposite of where you might think tranexamic acid is indicated, because there's not much clot breakdown going on. And if you look at a section of patients, you'll see that some patients have got high, and these have got a high mortality. The normal patients have got the lowest mortality. And then if you fall into the low hyperfibrinolysis, the low lysis group, these are patients that also have an increased mortality. And what is interesting is that lots of patients in that group actually have a severe brain injury as well. And it's, for a whole nother talk about why these patients fall into this category. But again, it's really because the problem of this test is not very good at discriminating what's happened previously and what's going on currently with that patient sample. Needless to say that if you fall into any of these categories, the high or the low, you actually do have high levels of fibrinolytic activation. And we'll talk more about the brain injury bit as we go through the crash trials. So, tranexamic acid, where does it come from? Well, the role in trauma is really all traced back to the crash 2 trial. Now, it had been used in a number of settings in surgery for many years before this. You know, the drug itself is quite old. It's been around for 50 years or more. And it found lots of roles in, you know, elective surgery and emergency surgery, because we know that fibrinolysis happens in those disease states or those surgery states, and it was helpful. And crash 2 really was the thing that, you know, blew the whole world open about tranexamic acid in terms of trauma, because huge study, 20,000 patients or more, that said if you give it versus placebo in somebody not who's bleeding but you think is bleeding, then it is associated with a mortality benefit. Now, you'd say, well, that's great, straightforward, the world should move to using tranexamic acid, but this is probably one of the most controversial trials and the most talked about trials, you know, over for many years, and people are still talking about it and what it means in the trauma community and the hematology community, because there are issues about the trial and how you understand it and how you interpret it across different systems, because it was run in a number of different countries with very different trauma systems. Sub-Saharan Africa clearly has a very different trauma system to the UK, the US, or Australasia. But I'll put it to you that if you're bleeding and you're a human being, then you bleed in the same way. It doesn't really matter where you are in the world. And in a large study like this, you know, there was undoubtedly a survival benefit. And then people would say, well, the survival benefit wasn't that much. It's literally a 1% difference. But in 5 million people who die from trauma every year, 1% is a large number of patients. So we're going to go through the trial and talk about some of the bits that are difficult to sort of get your head around. So the timing is something that we're going to talk about a lot this evening, because timing is an important factor in all of the clinical trials that come out. So this trial, crash 2, if you gave the drug within 3 hours, there was a mortality benefit to giving tranexamic acid. If for some reason the patient received the dose more than 3 hours, not only was there no benefit, but there was actual harm, which is very, you know, hard to understand, because I can't think of any other drug at all where there is such a difference in the timing. You know, you would say, okay, well, it loses its efficacy if you know, waiting a long time, but to actually cause harm, you know, is hard to understand. And I'll give you my rationale for why it might be explained, is that when a patient has activated the fibrinolytic system, you know, they have a problem forming blood clots during that acute bleeding phase. But at some point, probably around 6 to 12 hours, maybe 24 hours, the bleeding has stopped. The inflammatory system has now gone into overdrive. And now you're dealing with a patient who actually is in a prothrombotic state. And so if you go to any intensive care unit and look at these types of patients 24 hours after injury, now everyone is trying to stop them forming too much blood clot. And this is when they get their VTEs. So, you know, if you're waiting for a time to give a drug, maybe this is because they've, you know, and you've got harm, maybe it's because they've transitioned into that different phenotype, and therefore that's where it's going to be a problem. The other headline bit for the trial was that the biggest benefit was in those patients that had a systolic blood pressure less than 75, so the severe group. And we'll see this comes up again in a number of different trials. So timing, very important. As we said, not only in that binary, it's more than 3 hours, less than 3 hours, but when the authors combined this with another big trial, the woman trial, so that was giving tranexamic acid to patients who had a postpartum hemorrhage, they found, so this is now 40,000 patients, very similar things related to time, is that over time, from the point that the bleeding started, you lost efficacy. So for every 10 minutes, you were losing about 15% of benefit. And if you actually waited up to 135 minutes, that's when your confidence interval lines actually cross 1. And so therefore, at that point, you no longer are sure that this drug is actually going to be working to provide benefit across your entire population. And that's the driver for why the best practice tariff for TARN, which TARN is being transitioned at the moment, but how hospitals are paid for treating trauma patients, the drug must be administered within 60 minutes of arrival on scene from the first responder, or if they've self-presented to a major trauma center. If you don't hit that target, you don't get paid. So that is a good example, of using the evidence to drive improvements in clinical practice. And most centers now will be giving tranexamic acid very early on arrival, and the paramedics in the guidelines talk about trying to give this as soon as possible. And that's why, because the benefit starts to lose, you start to lose it if you wait certainly for more than 2 hours. So some of the other trials that have come out in this area, which have really come from the more developed and mature trauma systems around the world, because there was, as I said, concern that is tranexamic acid providing a benefit to patients who have a whole load of other high levels of care delivered in terms of, blood product resuscitation, access to paramedics at the scene, doctors at the scene, versus, what would be a rudimentary approach to pre-hospital care in some other parts of the world. So the first one was this study that was published a couple of years ago now in JAMA Surgery. This is the STAMP trial, comes from the Pittsburgh group. And what they did is actually compared pre-hospital dosing, but they looked at slightly different doses. So they compared the standard dose, which is the 1 gram bolus followed by the 1 gram infusion when you're in hospital, an abbreviated regime, which was just a single bolus without the infusion, and then a repeated bolus regime. So that was 3 grams. And then they compared this to placebo. So what did it show? Well, if we look at the top here, very interestingly, there was only a clear benefit looking at mortality reduction in those patients that had the repeated dosing. Now, why might this be different to CRASH-2? We remember this is a much smaller group of patients. This is only now 900 patients rather than 20,000. And the power calculations that were done are, you had to have 20,000 patients to show 1% difference in mortality. So it's probably no surprise that in the all-comer group of patients here, that you haven't seen a benefit across everyone. But you look at time again here. If you now break it down into those that got it very early versus those that got it more than an hour, you see there is a benefit for having tranexamic acid. And again, the benefit sits within that severely group of patients with injury and shock. So those with a systolic less than 70. So consistent actually with the CRASH-2 trial in terms of where the subgroup of benefit lies. We published recently, actually, one of my PhD students, who's a paramedic from Saudi Arabia, came and spent 3 years with us. He published a systematic review looking at the impact of pre-hospital tranexamic acid in bleeding trauma patients. And that STAMP trial appears in this meta-analysis, and there's a couple of other studies that made it in as well. And these are looking at 24-hour mortality on the left and 28-hour mortality on the right. And again, they showed very clearly that when you group all of the data together, there is a mortality benefit when you give pre-hospital tranexamic acid in a patient you suspect to be bleeding. Now, the most recent thing, hot off the press really this year, is the PATCH trial. So PATCH was the Australasian study, 35 different trauma systems that started in Australia and New Zealand, and also some centres in Europe as well, latterly. 1,300 patients, again, trying to ask the same question about in a mature trauma system, does tranexamic acid have a benefit or a role to play? Now, the endpoint for this trial was different. This was looking at a longer term endpoint. This was a 6-month quality of life or a Glasgow outcome score measure. And I'm going to show you the results in slightly reverse, just to show you the problem of picking a very long-term outcome endpoint. So similar to the stuff I've shown you before, is that there is a mortality benefit if you're looking at 24-hour mortality and 28-day mortality. Tranexamic acid, saves lives. But the primary endpoint, so how the health study was powered, was looking at this thing called Glasgow Outcomes Scale Extended. And this basically breaks down people into 8 different disability states or health. And this is measured at 6 months. And you can see there the sort of color coding at the top. So if you're on the greys or the greens, then these are people with good outcomes. And then if you're in the reds or the yellows and oranges, you've either died or you've got a very poor outcome. And you'd want more patients to have a favorable outcome. And for this study, there was no significant difference between this outcome for patients that received tranexamic acid or did not. And at 6 months, there was no difference in your mortality either. Now you might say, well, what does that mean for us in terms of we've saved some lives early on, but then really over time nothing changes? And this is really the fundamental problem for doing any trials in trauma, is that there's such a heterogeneous group of patients from the outset, but also there's so many interventions that occur. And my take is, if you try to pick one in particular intervention and to then say that's going to change the entirety of everything that happens for the patient's events and hospital episodes that have led to the outcome of 6 months, that's a pretty tall ask, because there's a whole load of other things and interventions that occur that would impact that outcome. And just saying tranexamic acid in the pre-hospital phase is going to alter all of that, I think is unrealistic. My take home from this is these 2 studies are actually very much consistent with CRASH 2. If you look at the early survivors, tranexamic acid has given us more early survivors by giving it. And if we give it to shock patients and we give it to those patients early, that's where you're seeing your maximal benefit. And this is those forest plots again from this group of patients, is that if you wait, you have less likelihood of achieving an important outcome. Certainly they looked at over 2 hours for patch. There's been some talk about administration, how we give it, and some of you may be involved in the CRASH 4 trial, which is obviously looking at brain injury in older patients and different dosing regimes. We did something with St George's Hospital, looking at dosing with the intramuscular route, obviously of interest for resource and poor environments as well, and the military. So what was always the concern about giving tranexamic acid intramuscularly was that in a shock patient, if you're injecting it into a muscle belly that isn't receiving much blood supply, then you might have a delay in actually getting the drug into the bloodstream to actually have the effect. And this was a small study of 30 patients who we specifically picked, the sick patients. And we found that actually there was, reasonable time window actually to achieving a therapeutic effect. And if you compare this to how long it takes you to set up and actually get a cannula into a patient with severe shock, I think this is fairly comparable. So there's lots of work now going on looking at, auto injectors and other ways which might, be of benefit for systems where you can't actually get intravenous access to a patient, either because the clinicians are unable or you just don't have the setup. Okay, so that's about hemorrhage. So we'll think about brain injury now. Bit more uncertainty, I think, is fair to say, around brain injury, because there's some clinical trials in the field, but are a little less consistent. So CRASH 3 came, after CRASH 2 to look in a similar way. Large study, lots of the same centres participated, and the idea was that if you're bleeding, from hemorrhage, and you're showing a benefit, if you're bleeding into your brain, you might even show a greater benefit, because you don't need to have much blood in your brain, obviously, to have a very bad outcome. And so this was a trial that was changed midway through in terms of the dosing, because when the trial came out, they realized that actually we should be giving the drug early and you had to give it within 3 hours. And so they changed midway through to actually make sure all the dosing was done early. And it was for patients who had a lower GCS, so less than or equal to 12, or they'd had a CT scan which showed that there was some intracranial blood. And importantly, they had to have no major external bleeding. So this was really trying to look at that group of patients who had evidence of a brain injury. And this was the same dosing regime. So it was the crash 2 protocol, so the bolus dose versus the infusion, with the infusion versus placebo. And it was, again, slightly controversial largely because of the way they actually presented some of the results. But 28-day mortality for TBI-associated death showed no significant difference, because the confidence interval here, 0.86 to 1.02, so it crosses 1, therefore there is no difference with certainty to say that these two groups had a different survival percentage. But in the subgroups that were predefined, they looked at those patients who had a mild to moderate TBI, so we're starting at the bottom of the page here, with GCS 9 to 15, and this was significantly different. This was 5.8% versus 7.5%. And the confidence interval all sits less than 1, so you can be certain that this is a real effect. Where the controversy came is now you look at the middle group here, so those where you've excluded those patients with a severe brain injury, so those with a GCS of 3 or bilateral unreactive pupils. And it depends on really where your bias sits for whether or not you think this is a significant difference or not. And I won't bore you with all the methodological arguments about statistics, but this confidence interval sits at 1. So does this mean this is less than 1, at 1, more than 1? It's a 1, so it's difficult. But if you just in lay terms look at this, in the TXA group, 12.5% is definitely lower than 14%. So in my mind, this is a difference, and this is a significant difference. What's hard to understand is why you are seeing a difference, across those different brain injury sort of categories. But overall, at 28 days, there isn't a difference. But time, very important again. So if you have a mild to moderate brain injury, there is a very steep slope the longer that you're waiting to give the drug in terms of efficacy. And you'll see here, it starts to cross 1 around 3 hours or 4 hours. So again, you have you better the efficacy, the quicker you're getting it into your patient. And some more nice infographics, if you like, numbers needed to treat for how many patients need to save a life from a brain injury death. This is again come from the group that have run the crash 2 trials. So have a look on their website if you want nicely, easily digested infographics here. But this is really just showing you that those smaller numbers needed to treat are in those patients with the mild to moderate head injury. And if you have a severe brain injury, so GCS 3 to 8, there probably is a benefit, but you've got to treat far more patients to show an improvement. So likewise, in the way that crash 2 was then dissected and repeated really by mature trauma systems, that's exactly what's happened here. So this is a group that's part of the ROC consortium, so they do pre-hospital trials in the United States and Northern America. And this was led by Marty Schreiber and Susan Royal. So this was looking at patients with suspected brain injury. And again, they had to not be shocked. So systolics greater than 90 and then have a GCS less than 12. Again, they looked at different regimes. So they looked at a standard infusion as dosing, as in the crash 2 protocol, versus a 2-gram bolus versus a placebo. And they looked at a smaller group of numbers because running these crash trials is absolutely huge. It takes you years. And if you want to look at mortality, that's what you have to do to, you need huge numbers of patients to look at small difference in mortality. So they again looked at the simulated patch was run, and they looked at the 6-month Glasgow outcomes score at, again, splitting into favourable versus non-favourable outcomes. And again, no difference in those two different, combining all of the tranexamic acid groups of doses versus the placebo, there was no significant difference. Now, when you look into the trial, this is the problem with, dosing patients early, not just with tranexamic acid, but with any intervention. As paramedics and as doctors, we have to make a judgment call whether or not we think somebody has got the disease state that we're going to give an intervention for. And it's obviously very hard. The clinical signs that we have to go on are very vague sometimes, and they can also occur in 2 different disease states or have no disease at all. So these are patients who were treated because we thought that they had brain injury. Now, when you look actually at their AIS scores, so the abbreviated injury scores of the head, so these are now patients who've had a CT scan and actually working out the grade of the injury. So as you'll see here, 0 is no injury in the brain and 6 is non-survivable injury. 25% of your patients had no injury to the brain. 5% of patients, or 5 or 6% of patients had, only a minor injury. So, if you're giving a drug because you're thinking it's going to work to affect, bleeding in the brain, and 25% of your patients haven't got that, then actually you're an underpowered study. And this is something we see consistently in all the trauma trials, is that we enroll patients because we think they have the problem. And actually, because we don't have good diagnostics to pick up these things, we end up recruiting a whole load of patients where there was never going to be any benefit because they didn't have the pathology in the first place. And it's even worse when you look at the patients who have intracranial hemorrhage on the CT scan. Actually, only 60% of the patients actually had blood in the brain. Now, it's not to say that tranexamic acid may not have a role in patients with subtle brain injury that you don't detect on the CT scan, but this is just to emphasize the point really that patent stratification is actually a massive area that the whole of the trauma community needs to get better at if we want to see clinical trials, because the vast majority of trauma trials are actually negative, and this is largely because we're just recruiting patients who we think have the pathology but turn out to not actually have it. Now, similarly, there was a meta-analysis done trying to look at the whole of tranexamic acid in trauma, and they lumped together actually patients with any injury, so not just brain injury but hemorrhagic injury as well, and they managed to pull out a large number of studies. I can't remember now off the top of my head, maybe 30 or so studies, but it ended up with over 40,000 patients. And you'll see here that the 24-hour mortality was no significant difference, albeit it's just crossing 1. You can obsess about these things, but generally speaking, there is a trend towards a lower early mortality. And at 28 days, there definitely was a significant reduction in mortality. What was the crash fall we sort of talked about, but what I wanted to talk about was blood clots. Now, one of the risks that people have always cited about tranexamic acid, and in particular the Americans who took a lot longer to come around to the whole idea of empiric use of tranexamic acid, was this idea that if you're giving it to patients who have not got evidence of hyperfibrinolysis, or actually they have low levels of fibrinolysis, then you might be making more blood clots. And the argument was that if you've got patients where you're stopping clots from being broken down, then you might actually make too much clot. The simplistic way to think of this is that tranexamic acid does not make you clot. The clot is forming because the body is making a clot. All that tranexamic acid does is stops clots being broken down. And clots are made in trauma because there is bleeding or there's a problem in your brain. So this clotting is a normal part of the process of dealing with the problem. So conceptually for me, I don't think that you can say that tranexamic acid promotes blood clotting. That's not to say that it may rather have a problem in terms of more patients having blood clots, DVTs and VTEs. Now, is there any truth in that, in the data that's being collected in the randomized controlled trials? Well, the crash trials found no difference between placebo or tranexamic acid in terms of whether or not it was an arterial thrombus or a DVT or a PE. The arguments always cited against crash trials is that it's been done in lots of resource-poor countries. You aren't monitoring VTEs properly, and therefore you're not really reporting true event rates. The patch trial, was done in Australasia, majority, and they actually did a formal screening to look at day 7. So everybody got a screen for scanning the legs to see if they had a DVT, and there was no significant difference in patients that had tranexamic acid or placebo. When we looked at this in our meta-analysis, however, in pre-hospital dosing, so this was the STAMP trial and then a couple of other trials, there was evidence of more VTEs in patients who had had tranexamic acid. The big confounder in this is that to get a VTE, you have to survive. Now, if you die from your bleeding because tranexamic acid hasn't been given to you, you can't get a VTE. But if you've had your life saved by having tranexamic acid, 5 days later you're in an intensive care unit, you might just develop a VTE. And certainly this is a message which is fairly consistent in this meta-analysis, the same one I showed you, which lumped all the patients together, brain injury, hemorrhage, the whole lot, is that there are more blobs on this forest plot that sit in the favours control side, suggesting that actually your VTE rates might be higher in those patients who have had tranexamic acid. And I think, there's a lot of work still to understand, what's going on here. But, simplistically for me, it has to be that tranexamic acid is causing more people to survive. And these patients are all, anyone that has severe injury is at risk of having a VTE because the inflammatory system's gone into overdrive. And, a brain injury, someone that sits on the intensive care unit, can't have the standard VTE prophylaxis because of the risk of bleeding. Spinal cord injury is the same. Big pelvic injuries, people are slightly cautious about giving chemical prophylaxis. These are exactly the patients who have also had tranexamic acid before. So there's a big confounding that's going on here. And I'd put it to you that it's much better to try to deal with a VTE rather than somebody who has died. So, you have to be perhaps aggressive in your VTE prophylaxis for patients that have survived, that initial insult and are having lots of other factors that are driving their VTE process. Okay, so that's the sort of clinical trials about the two topics of brain injury and hemorrhage. Now I'm just going to talk a little bit about equity of access, because this is something which is talked about in a lot of other fields as well, about the gender issues of patient treatment. And there's a very nice paper that was published by Tim Nutbeam and also the authors in the crash trials, looking really at two different data sets. They looked at the crash trial data set in the UK, and they also looked at TARN data to understand whether or not there was any sort of sex discrimination that was going on. And what they found when they looked at the crash trials is that this is UK patients only, so smaller subset of that 20,000 initially, is that the benefit of giving the drug in both of the trials was showed that when you combined it, that women and men benefited just the same. I mean, it sounds obvious, isn't it? Because it is obvious. But there is some evidence to suggest that men and women respond differently in trauma. But for the regards of tranexamic acid, if you give it to a man or you give it to a woman, then it is actually equally as beneficial in randomized controlled data. But in real world, this is now looking at TARN data. So this was, I think they had, tens of thousands of patients that were in the TARN data set here. Is that, so what are people doing, up and down the country in terms of the administration of tranexamic acid? Well, it's very different actually. Is that if you are a woman, you're much less likely to receive tranexamic acid. And this is being split into those patients using the BAT score, which is a way of determining the bleed risk, really. It's a couple of clinical parameters that go into it. But if you've got a low risk of bleeding, actually the disparity between men and women getting tranexamic acid is even higher. As the patient, risk of bleeding starts to go up, then you start to get a bit more parity, and the very high bleed risks, then actually you're probably treating them in the same way. But for the whole chunk in the middle, more than the middle really, most of these patients are actually apparently being treated very differently by pre-hospital and emergency providers. So when I first saw this, I thought, well, the trouble with this is that men and women often have very different mechanisms of injury. And there's something for me which, you can't simplify it just down to sex, because, women tend to live longer. Men are much more likely to have penetrating injury, and also, road traffic accidents. Men form the bulk of trauma patients. Women, in any data set, women are appearing in trauma centres, but these tend to be, the majority of these patients are older patients who are falling over with low mechanisms of injury, sort of a fall from standing. So that was my working hypothesis. So I set my PhD student Atik from the paramedic from Saudi to look at this in a slightly different way. So we also looked at the TARN data set to see whether or not there were any other biases at play that might be explaining why there were some differences going on. So this is it's coming out in the International Journal of Surgery. That's the reference there. It's available online. So there are criteria by which TARN measured whether or not you should or should not have received tranexamic acid. And these are generally if you were in shock, bleeding, you've got any blood products, or you were needing an operation for hemorrhage control, and there was a list of 50 or so procedures. And then we broke this down using the TARN data into the early and the late data sets. So we looked at the immediate effect of the CRASH 2 publication and working itself into JRCAL guidance, so the 2013 to 15 cohort. And then we looked at the later cohort that we had up to, which was 2017 to 2019. And the real good piece of news is that tranexamic acid was being administered to far more patients. There was still a lot of work to do, as you'll see, because we're still we're missing a lot of patients. But I'm going to show you those types of patients that we're missing is actually very interesting, because it's not universal. We are treating patients differently. So this is looking at the frequency of which pre-hospital tranexamic acid is administered. So just the broad numbers on the left-hand side here. And it won't surprise you that most of the patients are appearing in the penetrating and the road traffic collision group. And black bars are men and women are in white. So there's far less women that are, trauma patients, as I've said, but the most of it is appearing in those patients who have had the high mechanisms of injury. If you look then at the patients who are having, or where they're having tranexamic acid rather, you'll see it's very different across the different mechanisms of injury groups. So black on the right-hand side now is the pre-hospital administration. Grey is emergency medicine. And then white is their patients never had tranexamic acid. Important thing to remember through these slides is these are patients who are all eligible to receive tranexamic acid. So they triggered something in terms of they were either shocked, they were having blood transfusion, or they went on to have a hemorrhage control operation. So these are not all comer patients. These are a group of patients who we know should have actually received tranexamic acid. And you'll see the biggest groups here are those patients who are having falls less than 2 meters, the smattering in the other groups. But even in the other groups, we are not universally giving this drug to everyone who should be receiving it. Then when you look at age, you see that there is a problem, because the older you get, even though you're eligible to receive tranexamic acid, you are much less likely to get it. Now, there is definitely an interaction with sex. And when you do the comparisons, you'll see that, women, represent an older group of patients, are more likely to have the low mechanism of injury, having the falls. But they also are having, men and women are having a drop off in administration as they get older. And when you look at, the groups that we're sort of most attuned to in terms of, the guidelines, tell us if they're in shock, then you must get tranexamic acid into the patients. Whilst we're a little bit better than, the non-shock patients, there's still the white is the no TXA, black is pre-hospital, grey is emergency medicine. There's still a whole chunk of patients here who are not receiving tranexamic acid despite having signs of shock, and that women are receiving it less commonly than men. And this is sort of showing you similar things if you look at the age. But there's an even bigger drop off in age, is once you get above the age of 65, you are now running into sort of less than 40%, maybe a third of patients who are in shock, might be getting a blood transfusion as well, and are not receiving tranexamic acid. So I think there's a lot of work that we need to do as a community to understand, why we're missing these patients. Now, there are some, problems with the data set, and the astute among you will be saying, well, if you're being triaged in pre-hospital to a low-level fall, it might be that it's either a tech crew that's going to the patient who doesn't have tranexamic acid, therefore they can't give it to the patient. If it's actually being given as a call, to respond in a longer period of time, you might be getting there 8 hours after injury, and therefore, tranexamic acid is no longer indicated. So there are some, it may not quite be as stark as I'm presenting here, but I think, there is definitely a message across here around, there is inequity of access, which is related, potentially both to gender, but also to age of the patient. And when you do the multivariate analysis on here, there are certain things that are, that always consistently coming out with who gets tranexamic acid. And when you, put all the factors in together, because there was, clear dependency between these factors in pre-hospital. But these are the things that, as a clinician that's seeing, you will know, you don't know very much because it's, you might not have history, but these are things that you should always have. What's the sex of the patient? Do they look old? What's the mechanism? What their basic parameters are doing, and was this a air ambulance crew or not? Is that air ambulance crews much more likely to give tranexamic acid if you have shock or you have a lower GCS. You are slightly more likely to have it. Penetrating injury patients actually have it as well. But women and age are things that are, coming out here as consistent messages. And I said the thing about the time, there is some confounding because it obviously depends on, the category that's being afforded the call itself. But these are looking at the average scene times, across the national system. And, you'll see even with those average scene times, there's not much of the black that sits on the left-hand side. So this is the opportunity, people had to get tranexamic acid into the patient. And these are eligible to have tranexamic acid. If you were to say, well, okay, there might be some other reasons and we're not going to give it, but shock is sort of consistently up there in most guidance and most, clinicians' understanding of where tranexamic acid has a benefit. But still, less than 40% of patients are actually getting tranexamic acid in that, before the average scene time. and the patients then move into hospital. And finally, just going to talk about different types of dosing, because you've seen in some of those trials that there were different dosing regimes that were used. And the argument's always been that the 1 gram bolus followed by the infusion, certainly for the in-hospital side, is quite difficult to administer. We at the Royal London have done some work on this because we've messed around with regimes as well, largely because we were finding it difficult to actually administer the infusion. We then dropped the infusion, and then when some of those trials came out that I showed you, we actually then moved to a double bolus to try to get a higher dose of tranexamic acid into the patients. So this is the sort of timeline that we were looking at this, and there was some other changes in practice that were going on as indicated here. And effectively, we just wanted to see how effective those doses were on the outcome, but also, were there any changes in the adverse events as well? So we looked primarily at the mortality at 28 days, but then also looking at VTEs and multiple organ dysfunction. We have a long-standing research program at the Royal London where we are collecting blood samples and clinical data on all the trauma patients. So we had to then, chuck out a whole load of patients because we needed to, retrospectively work out when they got tranexamic acid in relation to the blood samples we took, but also to make sure that we knew categorically which type of regime of tranexamic acid they had. The problem with this retrospective data is that when you break it down into those different dosing regimes they had, you end up with slightly different patient groups because it's not randomized data. And for some reason, you have different, so the bolus plus infusion, for example, only 60% of those patients were male versus sort of high 80s for the other groups. And that particular strategy, the bolus plus infusion, also had groups or had patients who had a higher injury severity score as well. And they had a higher base deficit, so they were more shocked. But when you put it into multivariate regression, the important thing here is that when you adjust for all the other outcome variables that are likely to impact mortality, is that whatever dosing that you went for, it didn't have an impact on outcome because it's crossing the confidence intervals, go both sides of one. So really, we believe that this, although it's not conclusive data, suggests that actually there is no difference to the dosing regime in terms of outcome, but there are logistical reasons why you might favor the bolus only dosing regimes, because trying to get the infusion in is a problem. The other thing, which is, again, my hypothesis, is that if you have a problem with moving into that prothrombotic state, and the crash trials said that if you give tranexamic acid more than 3 hours after injury, then it causes harm. The infusion runs for 8 hours. By definition, that is past 3 hours. And so it always struck me as weird that we would saying we had to give a drug early, but then we're also giving the drug late when it was causing a problem for patients in terms of poor outcomes. And I think that was just more of the same really for those things. So this is my final slide. This is what we do at the Royal London now, and also with the London Air Ambulance. So if we activate the code red in hospital or out of hospital, we effectively give them 2 1-gram boluses. If we've got a brain injured patient, either with London's Air Ambulance or in hospital, and we determine that by a GCS less than 12, or we've put them through the CT scan and we can see some blood, or they've come in as a HEMS patient that is tubed, then we will just go ideally straight for a 2-gram bolus. And we try to simplify things so that we can just get the drug in as quickly as possible, because time is absolutely the most important thing in these types of patients, because we know that the longer you wait, the less efficacious the drug is.